and we're going to invite Jim McGuckin. Jim McGuckin is an interventional radiologist and director of the Philadelphia Vascular Institute and founder of Vascular Access Centers. And this is where the fun starts. This is where you get to participate, and I've already reserved the first questions. I'm reiterating. This happens at every one of these, as Sharon knows, that I make this plea for questions and not, sort of prologues to long-running debates. But we'll go ahead, and it never works. So, but I have to do this. So, questions, please. Go ahead.
Well, I'll ask a question, but I do need to give it a little preface. I'm not a neurologist, and I'm not an interventional radiologist. I'm an endocrinologist, and I was invited here by a patient who has MS. I'm not treating performance, but I wanted to learn about this particular area, and I appreciate especially the last talk because I think it was really a lot of data, and that's something that I like. Now, my sense is that before one can really do a good study, one needs to have the right conceptual framework. And I wanted to give an example from endocrinology, and that's an example of diabetes. Type 2 diabetes used to be considered one disease. And it's something that you may not really be up to date on, but type 2 diabetes is no longer one disease. So even though people have elevated blood sugar, both the genetic background and the physiologic disturbance is different in different people with diabetes, and treatment is different, response is different, clinical course is different. And this may be a naive question given that I'm not a neurologist and I don't know the field so well, but the question is, should we consider something different also something similar to that when it comes to multiple sclerosis? In other words, that even though the presentation may be similar in terms of clinical symptoms and the findings on brain scans, the different people with multiple sclerosis really have different pathophysiology, and therefore groups need to be selected in terms of treatment. And then the second question goes to Dr. Siskin, perhaps, or maybe some other people. Is there anything more specific that is known about what is really wrong with the veins where there is an obstruction? Is that something that's acquired? Is it something that may be present congenitally? Is it fibromuscular? Is it deposition of something? I wonder whether you could comment on that one.
So I'll take the first one. So I think that all neurologists, at least all MS specialists, are acutely aware of the fact that the diagnosis of MS is a clinical diagnosis, and we don't know that we're dealing with a single pathophysiology. And I think that there's a lot of thought that there are subtypes, and the subtype which is most obvious but not necessarily a different disease is the person who has primary progressive MS, who never gets attacks and just has a slow progression. They're more likely to be male, they're more likely to have an elderly age of onset. That disease is very different from the disease that begins in young women in the 20s and has a relapsing remitting course. I think that the single subtype that I think we are confident that we've separated out is a condition called neuromyelitis optica, which is an antibody-driven disease. We have an antibody which I think is relevant pathologically to that condition, and the treatment is an antibody treatment. And I think that probably is not MS. I think it's a different disorder. But we don't know how to, unlike type 2 diabetes, we don't know how to separate out the different groups.
We don't know it in type 2 diabetes
You
either.
just to answer your question, just to continue on this theme of we don't know. The fact is the pathology really hasn't been well established. There's been some slight opening of the door a little bit. Just at the last ECTRIMS meeting, the Cleveland Clinic presented some autopsy-related data that looked at some specimens of the veins and found some abnormal valves and other just abnormal tissue within the veins of MS patients that seem to occur more frequently when comparing them with specimens from healthy, although it's hard to call a cadaver specimen healthy, but cadavers with no known MS. And it was small numbers, but at least there was an opening of the door a little bit that, wow, there are some visible abnormalities of the valves in the vein and of just the tissue lining the vein there. So it's a start. To know whether it's congenital or acquired, we're just not there yet. We don't have a good enough handle on the pathology.
I think one thing that's important too is, we have an 82 response rate to our therapy, but what we really need to think about is the people that we haven't helped, right? Do they subsegment out, and is there a vascular component to MS and then a non-vascular? So I think there's a lot of things to be learned from the patients that don't respond.
Well, I'll just bang the drum on one of my favorite topics. Is again, it's not clear that there's one form of venous problem that's causing this. It's the venous obstruction itself, and yet we know that there's round up the usual suspects. It's the valve, but there are lots of things about the valve. But it also is other areas in the veins. So the common thread is in this conceptual framework is that there is some form of venous obstruction that's causing some flow disturbance that's getting translated to the blood-brain barrier. And after that, well, we don't even know that, but that's the idea. And the idea being, again, that I don't think we can look for one precise, say, genomic screw-up in valves and expect that that's going to answer 100%. Nothing's 100%. We talked about that. We have many other areas, again, where, like Bulent showed you, and I think it was a good point. I look at May Turner, which was that iliac vein compression. If people go into the emergency room, you go in and you have a kidney stone, you have nothing related to a vein. In 60% of patients, you're going to see a 30% narrowing of the vein. In 30% of patients, you can see up to a 70% narrowing of the vein. It's only when you get up to the really severe narrowings that people start to have symptoms. But it's not a quantifiable tipping point. It's very difficult to really assess where this happens. Forget about something as complex in the brain. I'm just talking about your leg, And when people get symptomatic based on what level of obstruction, it is difficult. We just know at one end of the spectrum, it's not good, So.
Let me just comment. Did you want to?
I was just going to say real quick that, we have a bell curve of patients that are born between 1955 and 1965. So chronicity, or the presence of disease, in my mind, plays a role of what's going on with these valves and how they change over a patient's lifetime. We're not seeing the majority of patients at one end of the spectrum or the other, but they're in the middle of this age group. So I really think chronicity over time, really dictates how these valves are changing or thickening or whatnot, because the impact takes some time to present itself.
Go ahead, Jack.
Just point out, you can see why neurologists are confused. You can see why there's questions from the neurologist, I would hope. And you also see why we need collaboration. If we're going to solve this problem, we need all the brain power from all the people involved working on this problem together. And that's where I'm hoping that we're going from here.
Yeah, I think that's apple pie and mom, and we're with you on that. But, I think that this shared confusion really has to be identified with on all sides, because it's not something we can figure out on our own. So here's a question from the audience that came in on text, and I don't know, anybody can answer, can chime in, just see what you think. It's a real life case. My wife has a cranial cavernous malformation deep in the brain that was resected in 2000. Now, she has MS. Is there any relationship or connection between cranial cavernous malformations, CCSVI, and MS?
I don't know of any connection between cranial cavernous malformations and MS, or no connection with CCSVI. I don't know that. Jack?
Well, yeah, I don't know, but I think I know where it's coming from. They obviously went in and tried to correct the malformation of the veins, and then she got multiple sclerosis, so maybe that causes the venous insufficiency. But I would just remind you, and I have asked the surgeons this, is that my colleagues who are cancer doctors, when they're head and neck cancers, they take out those veins. And they don't get MS afterwards. So I don't know, I still think we just don't know that. We know that we take out the veins. The consequence of that is not multiple sclerosis. So I would say that there's probably not a relationship with her situation, but I don't know.
Well, I think what they're getting to is that obviously an AVM you've got now, basically you've got a high pressure in your veins. Not as a result of the surgery that something's been removed, but for sustained time she had this AVM, and therefore the veins were not normal. So like a dural AVM or something like that. Having said this, who knows? We don't have any definite correlation, but this is why I kind of have stopped, getting terribly, concerned about figuring out these specific associations and more kind of, again, shifting, as I said before, the debate to, okay, this may take decades to figure out the answer to some of these questions. It's 150 years since MS was first, discovered or coined, and we haven't quite figured it out yet. It's a little presumptuous to think we're going to knock this out of the park because it's much more complex. Now, let's focus on the patients and the therapy and see if we can remove, first, placebo out of the equation, and secondly, see if there are demonstrable, objective, quantifiable physiological metrics that improve not only in terms of physiology, but in terms of performance and function.
Well, no, I agree. We see a lot of AVMs. We don't see a lot of MS in those AVMs.
But there are symptoms where there are brainstem AVMs that the patients do have MS-like symptoms. And once the AVMs embolize, there's a resolution of the symptoms. So my caution, and for this patient particularly, recanalization is a strong possibility. So it just,
Right, so that it's true that there are many symptoms that mimic MS, and I think that one of the diagnostic challenges for neurologists is to figure out which patients actually have MS and which ones have some other alternative diagnosis. But there are very few people who have AVMs and MS. I mean, that's not a common association.
Yeah.
But I'm very heartened by this clinical trial. I think that it sounds like a great clinical trial. That's the kind of study which needs to be done to prove or disprove.
So okay, let's put it on the table then. So if that's a great trial and you like it, you want to do a trial on it? You want to do a trial, you and me do a trial.
Well, I mean, I'm willing to do a trial like that, yeah.
Okay, well that helped me a lot.
I think he's moving to Albany.
No. That's okay. That's fine. I can text. It's all right.
Well, I live in Berkeley, which is close to Albany.
Okay, right.
Let me ask a technical question to Gary. How do you do placebos? Don't patients know when they get a balloon blown up? Don't they get pain? And can you differentiate sham versus treatment in those patients very well?
Well, I'm pretty confident that we can. I mean, we're doing them in a controlled hospital setting with ICU nurses providing a high degree of moderate sedation, and I think that we can get patients sedated enough where they shouldn't know what has happened to them.
Let me jump in on that too. In Buffalo, I'm familiar, and you may know also, but in the Buffalo trial, Jack, they do very careful sort of legitimacy of blinding questionnaires afterwards. But did you think you get treated or not? And then they correlate all of this, and they're pretty able to blind it. Now in our trial, Doug, we're going to put them under general anesthesia for an hour, and then we'll also, no, seriously, that's.
How do you hide the post-procedure discomfort that many patients do have? That's the real issue for me. Because between hearing the MS pop of the balloon going up, it's well talked, spoke about. But there's also the post-procedure discomfort.
Yeah, and what they do in Buffalo, and they don't go under general anesthesia, they're like Gary said, is that all patients get a pretty good pinch on the neck at the time. And now, having said that, the proof is in the blinding legitimacy questionnaires.
That's
if
right.
they came up and said, everyone who said they got treated was right, and everyone who said they didn't get treated was wrong, then you'd be right. But this is from Adnan Siddiqui, and they're very pleased with how their blinding is going.
That's right, and I think that's legitimate. I think with any blinded trial, something like this, you have to ask the patients what they think happened. And you ask them at the time of the procedure, and you ask them at the time of first follow-up as well, just to see what they think. And then obviously, if everyone is right, then we have a potential problem there.
Yeah, so this is an issue which is not easily solved by. I mean, I think you need to assess how blinded your trial is, but if you have a procedure which really works well and people guess if they did well that they were on the active treatment, you're going to get confused, even if they weren't truly blinded.
Right, but I would hope that I guess potentially some of the more objective measures that we have in our trial will help to mitigate some of those.
Well, no. I think you will. Right. Yeah.
Okay, let's have questions from the audience. Yes, sir.
Yeah, I'd like to ask two questions. One question to Dr. Siskin. If there is there any particular difficulty in doing venography and angioplasty on the azulus versus the jugular veins?
From a technical perspective?
So let me repeat the question. The question for those who couldn't hear is, what are the specific difficulties or potential problems in treating the azygos versus the jugular veins?
Is there any?
Well, I mean, you try not to sound too conceited with ability, but the fact is that our ability to do that has definitely improved with time. I mean, it was challenging in the beginning, and with experience, I think that we've improved our ability to reliably catheterize and assess these veins. It's interesting, when we first started doing this, we just assumed, oh, these are big veins, it's not a problem getting catheters into them. But there are challenges. There are challenges unique to each vein in terms of putting a catheter from the groin up into each of the veins. And yet, we have a lot of different shaped catheters that are really designed to mimic the anatomy that we're seeing in patients, and we think we have the tools to do that reliably. The azygos vein is challenging because of the turn it takes. So you literally go up, then you have to go all the way back down to study it, and it's challenging, but it's really been the rare patient that we haven't been able to do that.
And I also have a second question more to the neurologists, and that is, as a patient who has have had MS for about 20 years, and I have tried steroids, I have tried Copaxone, and I have tried CCSVI. I came into the conclusion that I will never ever again in my life take any drugs that either I can measure the result or I can feel better. And I can tell you the two things that actually helped me is steroids and CCSVI. Because my walking improved, I got my vision back from steroids, I got my walking improved from CCSVI, my fatigue went away, and I doubled my exercising at the gym after the CCSVI. So I would really like to see the medical community to treat the CCSVI as yet another option next to Copaxone, interferon, steroids, and CCSVI.
Well, that's what Dr. Siskin's controlled trial is to try and demonstrate, is that actually has a benefit.
It's just another option to have.
Right. There are many patients, and most of the treatments that you mentioned, I don't think, they modify the course of the disease, but they don't make people better necessarily. But there are many patients who feel better after they've been put on those treatments, and I don't know what the basis for that is, but none of the clinical trials showed that.
I would point out that one of the things that Dr. Siskin said that may have escaped you is how difficult it was for him to learn how to do this, to be surprised by the variety of things. And every endovascular surgeon says that. They need experience. So my thought is, if you or your friends are going to have this, go to some places doing research and doing a lot of it. And be very careful of the shopping center commercialized centers that have no business doing this. The dialysis doctors who all of a sudden said, oh, I can make a few bucks. Stay away from those people, for goodness sakes.
Yes.
Okay, so let's say Dr. Goodin and Dr. Dake, their study is complete, and the results are, let's just say in a fantasy world, that they're conclusive.
Dr. Siskin's study is much closer to completion.
Okay, great. And we participated in one of the studies, so we can proceed. What's the next step? Do we have to then prove it to the next neurologist? Or, because you're all, too many cooks in the kitchen kind of a thing. Everybody has their own information that they're looking for to be satisfied.
Well,
my fear is we're just going to go around and around and around, and no one's ever going to be satisfied. And then in the meantime, years are going to pass and pass. What is the golden standard that you're looking for? And then, let's say you get it, what's the next step?
Let me take a whack at that, or well, anybody can, but I think the key is what you're trying to do in this is if you really, is just illuminate the next step that could take, and you're building a folio of experience and outcomes that are done in well-controlled, high scientific studies that could lend, in your mind, the fantasy world, legitimacy to this that builds up to the point where then it's just going to go up to the point where it will be easier to get NIH funding for this. For right now, it won't be able to do that. So and again, it's not just one trial. It has to be, whatever Gary's trial shows, it has to be recapitulated, guaranteed, by another trial that was done. Even could be the same exact, trial, the same protocol, but somebody else has got to do it. Somebody else has got to do it, and at that point, it reaches a tipping point where it's undeniable, and people say, okay, now we're really ready for, a multi-center, multi-institution trial, not a site-initiated single trial, but a number of centers doing the same thing with the protocol that now we have, in multiple studies, has showed to be the one that we think is best. And at that point, and again, I think that's the direction. Yeah, obviously, it's not a straight line path, but I think that, it's just a step to the step, and Gary's a great first step. Doug and I are going to do another step. This is recorded,
I was just going to chime in just real quickly. I mean, the fact is, I agree with Mike. I mean, it's not going to be one answer, and you may find that frustrating. People may find that frustrating. But the way I look at what we're doing is that we hope to find a signal amongst all the noise. I think that's a fair way to look at it. And I think that if we can show that this makes any difference at all, what that's going to bring about is a lot more people all of a sudden getting interested in this and wanting to work together to even get more definitive answers. Because I'm sure no one designs a trial thinking that it's going to be the ultimate trial in the whole entire world. We're looking for some signal that this makes sense to do, that there's a reason to do it, that it affects change in patients. And what we hope is that once we're able, hopefully we'll find it, but we're objective and we'll do the best we can. But let's assume we do find it. That'll allow people in their position and other positions to say, maybe there's something to this. Let's really jump, headfirst into this and answer all the questions now.
And one of the obvious milestone tipping points is firmly and finally understanding how much of this is placebo and how much is.
Well, yeah. Just to follow up on that, I think that the rules sort of evidence-based medicine, and I agree that evidence-based medicine is. I think it's an important tool, but it's not sort of the holy grail. But if you do 2 Class 1 studies, which I think his study would be considered a Class 1 study, that is sufficient to prove that the therapy works. I think we get concerned when there's one single center trial that shows an effect, and then another single center trial which shows no effect. And it's always possible that the one person knew how to do the surgery and the other one didn't. That's been said about the reason for the discrepancy between the ultrasound results. But I think that most neurologists would accept that. And the example that I sort of cited before is carotid endarterectomy, which is a blockage of the carotid arteries that supply the brain, which makes good sense sort of intuitively that you'd want to unblock those vessels in people who have threatened strokes, was an operation which was done, and most neurologists didn't believe it. And the vascular surgeons were doing it for 30 years. And then finally, there was a very high-quality clinical trial which showed that it did have a benefit, and they defined the criteria by which you make a decision that that person should get an endarterectomy, and I think the whole community now accepts that.
Yes, Jeff.
Just a general question, not to further muddy the waters, but it seems like they're already muddy, so what the heck. To start with Dr. Siskin, but I would be curious on the neurologists to give their perspective on this too, that along with the general thrust of studies towards this focused goal, which I think is great, there's some very fascinating work being done by Dr. Cook at Stanford that relate more to the causal theory that relates to CCSVI. I think he's working on animal study to show sort of this is a possible cause, and also the iron deposits in the brain. Forget which doctor that is, but again, there's been some studies that have tracked iron deposits again as a possible precursor to inflammation and demyelination, etc. This all sort of plays into this whole blood flow idea, and I know just to throw in one other patient perspective, I think that it's always kind of, I'm always kind of nervous when I talk to patients, and like, so I say, well, you had it done, and I said, well, what happened? And I'm always curious, like I'm expecting them to say maybe nothing or something, and they tell me there is a certain consistency to some of these things, some of them cognitive, like I didn't remember a dream for 2 years. And all of a sudden after having the procedure, I started remembering dreams, which is very odd, and I was almost afraid to talk to them, but then other people started to mention these things. And this sort of immediacy of a result also relating to oxygenation of the brain, which I think is sort of one of the universal anecdotal findings that I find in talking to a lot of these patients. I'm just curious how these other data points play into your thinking as neurologists about MS and brain health and how this might all fit together.
Well, I think that it's whatever these things are, they need to fit into what we think we understand about the epidemiology of MS, which is reasonably well established. So It's a disease not of the elderly, but of the young. The average age of onset is about 30. Virtually everybody that gets MS gets it between 15 and 45. There are obviously people in the tails, but it's very, very rare. So you look for something which happens to be maximal at that age. So iron deposition in the brain actually increases with age, but in different locations, and I mean, it's a very complicated thing. But I wouldn't have thought out of the blocks that iron deposition was going to be responsible for MS. We know that iron deposition occurs in Alzheimer's disease, Huntington's disease, Parkinson's disease, but those at least are diseases of the elderly. This is a disease of the young. I'd be interested in whether the venous drainage from the brain gets worse with age. I don't know that, and there's somebody here who probably does, but if it gets greater with age, then that doesn't fit very well. Why is it that MS is much more prevalent when you go north or south of the equator by an order of magnitude, in Canada and Scandinavia than it is in Brazil or Central Africa? I mean, some of that may be genetic, but it's not all genetic, and it's probably a lot of it's an environment. So I think we need to fit our ideas of how we think that we're treating the disease with what we think is a plausible cause. We know that the environmental factors, or we think we know the environmental factors, are general population-wide exposures. They're not like mercury in a stream. That's an unlikely cause. I mean, I don't know that mercury doesn't cause MS, but we think the population is exposed in general. We don't think it's little pockets.
Jeff, I think that's a really good point that you made. And one of the meetings that we had just before this meeting was to actually establish a research collaborative. And I can assure you that the basic science, iron metabolism, hypoxia, all these things were discussed as we need to bring all these people to the table. Dr. Cook was mentioned specifically to say, let's try to figure out the basic mechanisms as well as the clinical issues. So we are working on that end.
If I could just speak for the patients in general, though, I think they just want the neurology community open to trials and to hopefully finding treatment that works more effectively than the existing options. And what they really want is just open support, and they want your advocacy to get them into IRB trials so that we can get final answers. They want the support of the MS Society to learn more.
Yes.
Well, I might say that neurologists want a diagnosis. We want a standardized diagnosis that everybody can agree upon, so we'll know what we're dealing with and an outcome measurement that's consistent. I think that's the other side of the coin. So what are we treating?
Right. I mean, if ultrasound is worthless, which it may be, then we'd like to see the right test. We need to know how to make that diagnosis. Zamboni says ultrasound's 100%. Other people say ultrasound's 0%. That's very frustrating to neurologists.
May I ask a question? How easy to make the diagnosis of MS?
How easy is it to make the diagnosis of MS?
Since the MRI.
So before the MRI? Even after the MRI?
I don't think it was all that difficult in the majority of patients. I think that the biggest difficulty is in trying to exclude other conditions which could cause recurrent symptoms.
The reason I'm asking that is I'm not a neurologist. The patients that I've seen is extremely limited compared to your experience. But I have not had a patient almost who was not misdiagnosed until their MS diagnosis was made. It's almost around, they didn't know what it was, a couple of years. I have patients who were diagnosed with brain metastases by a neurologist after having an MRI that ended up not being a brain metastases. There's so many patients had difficulty even in that scenario. So I think it's not fair. I know that we have a problem in establishing a really good diagnostic, and my current opinion goes along with Dr. Siskin's. I think immunography is the only ultimate test, and which is very reproducible. There's a lot of information in immunography that you cannot get with other tests as effectively and accurately, but it's an invasive test, unfortunately. But the MS itself has had for years and then these patients before MR, I'm sure they were being treated with sorts of drugs, but there was no definite way to diagnose them for a very long time.
Well, I think that it is at the very beginning of the illness. I think it oftentimes is a problem. optic neuritis, which is a very, sort of conspicuous clinical syndrome, only half of those patients after 15 years get a second episode. So, but I believe that that's actually the same disease as MS, but we don't call it MS until they get a second event. I think with the MR, we are making the diagnosis much earlier in the course, but I don't think ultimately we're making it more accurate.
But we still have to allow that the revised McDonald criteria wasn't the first thing out of the box. Obviously, neurologists have been refining, revising, adding to, subtracting to what the actual criteria are for the diagnosis
And now they're looking at
for
data.
years. Yeah, and now there are lots of, so I mean, it's a detective story still.
Right, so the nice thing about the revised McDonald criteria is at least if you look at some of the larger clinical trials that use revised McDonald criteria, they have no false positives.
No, I'm not saying it's, I think it's great. I mean, it's up to sort of the asymptotically in terms, I'm just saying that this is the first, the fact that we're struggling to come up with a venographic criteria, a CCSVI, is probably not that unusual. I mean, it's not to be, it's not that unexpected. I would anticipate.
It's unexpected. I think the unexpected thing was Zamboni's report that it was 100%.
Yeah. And that, of course, we know is most likely not true. But I think that this is going to take a while to settle out. But I just, in the end, I think that it's going to. We need to get neurologists to sort of. We hope that they will take a little more ownership of that in terms of working with us to come to that, because otherwise we just can't collaborate and get the patients and look at it together.
Right.
Yep. Yes, sir.
Just a quick question for Dr. Siskin. In your study, post-blind, if the person gets the actual ballooning done, regardless of the EDSS score, will you then go in and see the vein health? So maybe they scored poorly, you go back in with the vein. Well, it was open, now it's closed again.
No, we're just going to follow patients with ultrasound. We're not going to do repeat venograms on patients.
The other thing that's sort of interesting, and again, Gary, we won't go into all the details, but some of his endpoint outcomes were suggested strongly by the FDA at this, and obviously EDSS might not be the one that we would all pick to be the be-all, end-all outcome. And so, I mean, that's not necessarily his choice. That was something that the FDA would like to see. And so, again, I think that may have to be refined as well.
Right, I mean, I think the goal of everyone involved in this trial was just to make sure that we were speaking the correct language. I think the biggest harm that we can do is to do a trial that isn't meaningful to the neurology community or to the patient community, and I think we just need to speak the same language. So, you're right, I mean, we're not sure. The theme of tonight is that there's so much unknown about this whole thing. Is this MS? Is this a completely separate venous abnormality that just worsens the symptoms of someone with an underlying neurologic abnormality? We don't know the answer to that question. And so right now, mainly because of Zamboni's work, we're going down this road that this is an MS-related phenomena, and we need to kind of figure out if that's the road we should be going down.
Yeah, good point. And here's a question that brings that into sharp focus. Have there been any discussions about congenital collagen disorders like Ehlers-Danlos and CCSVI?
You're asking me.
I'm asking you. I can give you my view on that. And we've seen a lot of patients with so-called POTS, which is the posterior orthostatic tachycardia syndrome in this, and they almost all have Ehlers-Danlos, and they don't have MS, but they do have CCSVI. And I think the problem, Jack knows this, but just so Doug knows, I mean, the hidden little secret on all of this that we all sort of know, but we don't dare kind of yet speak in loud voices about is that we're seeing CCSVI and things besides MS. Okay? And that, I think, was going to cause neurologists to be even more.
No, I don't disagree with what you're saying.
Yeah.
However, I'll tell you a story. I was contacted by someone with Lyme disease, who said to me, "I want you to do a venogram on my veins and look at this." And I said, "No." And he was very taken aback by my response. And it turns out he was a medical student. And I talked to him. I said, "I expect more from you." I said, the bottom line is that We are doing what we're doing based on literature that's out there, based on stuff that Zamboni's reported. Now, we can all be critical and we can all look at it, but the bottom line is that it's out there. And we're doing, the justification for doing what we're doing now is based on that. There is no justification right now for treating someone with Lyme disease or treating someone with another neurologic condition. I'm not saying, by making that statement, I'm not saying that it may or may not be a good thing. I'm just saying that there's no justification for doing it, which means it has to be done under research conditions. It has to be done by someone who puts in an IRB-approved protocol, and whether or not you involve other regulatory bodies, that's up to your institution. But ultimately, I just told him, I said, that's my thinking, is that the only way I would do this is if there was justification by from someone else's work, or by work that's being done under the supervision of an IRB. And frankly, I'm just maxed out right now. That's what I told him. So that's my opinion, and that really didn't satisfy him, but it's not to say that there isn't an association with other neurologic conditions. It's just other people have to figure that out.
Yeah, if you are mixed up and here in MRI, I haven't done anybody other than MS patient. I got a lot of requests, I returned them now too. But he had a high-grade stenosis on the MRI, bilaterally, let's say. Would you treat him?
My son? I don't know. I genuinely don't know. I mean, I would have to think about it.
It is a hard question.
It's a hard question. I don't know. You can put me on the spot. I'm not sure. I would have to think about it, and I would talk to people who were knowledgeable in the field and see if it made sense to do. I don't think I would just say yes right away.
And the other reason I brought up that earlier diagnostic thing is we honestly don't know that, just like you mentioned, there could be a lot of overlaps. Some of these patients may have MS, some of them may have other things. It could be an intersection between MS and CCSVI. Maybe there are a lot of patients out there that are having the diagnosis without the MRI, the diagnosis would still be kind of lingering right now, which makes me question that, there's even the diagnosis of MS versus CCSVI still has to be clarified.
How about another couple questions? Is that okay? And then I think we should wind up because we'll be right at 90 minutes. Yes?
Hi, doctors. Thank you for your time and input. I wanted to ask you a question. Each of you had mentioned the possibility of great disparities between the different trials that had already occurred. How can the medical field move forward in creating a consistent criteria and methodology for each of the trials so that there is not all of these questions about what the methodologies were in each of the trials, whether they were positive or negative?
That's a very good question.
Well, I think standardization of treatment patterns has to be one method to be considered. What balloons are used, what pressures they're put to, what size comparison that we use to size our balloons versus the mains diameter. And these are things that need to be kind of standardized because they can really affect outcomes.
I love living in 2012, but when it comes to this, I wish it was 20 years ago. Because the problem is that too many people know more or think they know more about this than they should. And if this was 20 years ago, not to demean anybody, but if this was 20 years ago, this wouldn't have necessarily been public information until a lot of this had been worked out. So, there would have been other studies that would have been published in journals, and the medical community would have worked just like we're working now to figure it out, only it wouldn't have been as easy for the patients to get all this information. Now, I'm not saying it's not better now, but it is creating a challenge for us because, we have a much larger audience watching what we're doing than we would have had 20 years ago.
Yeah, but you have to, you probably all know this, but after you'll treat someone, your phone will go off and you'll look down, there'll be a text and say, "Hi, this is Jose from Valencia, Spain. I understand you just treated Lou from Dake." And I'm absolutely convinced, because I've talked with Lou before this, that he and I have the same venous anatomy. And I just wondered, I go, Lou from Dayton. I just left Lou from Dayton. I walk in and Lou from Dayton's banging away on his, in the recovery room on his thing, sending it out to the world. The world is responding. The world is coming back in.
Welcome to the future. We're here.
We're in the future. There it is.
I've had patients tell me, like, "Doc, you got to get going. You have a flight to catch because you're treating my friend in Houston tomorrow."
Okay. Question. Last question.
All the studies I've heard about are short-term studies, short-term outcomes, and I was wondering if anybody's planning a study that actually studies progression, long-term outcome. because, I mean, there's the hypoxia thing, which it seems like it's a really definite thing, but then there's also like the venous theory of MS, et cetera, that sort of, implies that there should be a difference in outcome.
Yeah, every study that's done is going to have short-term and long. We're following our patients for 2 years, but we hope to collect data obviously along the way.
Yeah, I think what everyone should know in the audience, and obviously the neurologists, I hope already know this, is that the methods we have for treating these veins right now are not custom engineered for the challenge at hand. We're using tools and translating them from the arterial side to the venous side, and nobody's proud of that, and no one's trying to bang the drum that this is the be-all, end-all. These therapies that we're providing right now are, I think, have a born-on date, and they're going to be sensitive to time, and are probably not going to stand the test of time. And that's again the challenge, to get better therapies that are more durable, more sustainable.
But that's the goal, is to get the signal to prompt the people who are in that position to start moving on that. If there's signal that this is a meaningful outcome and it's a meaningful procedure, then people will start working in that direction.
Right, but long-term studies are critical, right? So, and they're few and far between.
Well, they don't exist.
Well, there's some long-term follow-up studies, but even for the medical therapies, we have 2- and 3-year data.
But I mean, what Dr. Dake was alluding to is that this is not a durable, general durable procedure. So if you're going to go long-term, if you're going to study something for 10 years, you're not just going to do them once and then watch them. You have to make sure that there's no more, stenosis, et cetera.
But you better make an impact on the short-term measure.
Yeah, exactly. I think you're right, Doug. Absolutely.
I'm not so sure. I mean, people are getting this done on the assumption or the hope that their progression is stopped. I mean, they do want to feel better, but they also, they're on this clock. They're just going to get worse and worse and worse and worse unless it gets stopped. And it's very important to them to stop the progression, or to know whether this will stop the progression.
But
good point.
In randomized controlled trials, when they have long-term trial, stopping of progression can also be assessed. You're going to look at everything on those patients. So that question will also be answered.
Well, with that, I want to thank everyone. We're so pleased. I know the Alliance is happy. So many of you came out tonight, given the inclement conditions. Thank you.